versus diets during a flare. Our speaker is Tina Patnode, who is a registered dietitian and nutritionist with 23 years of experience in medical nutrition therapy. She has a particular interest in the human microbiome, that is the microorganisms residing in the gastrointestinal tract. For several years, Tina worked in 4 gastroenterology clinics in Portland, Oregon, where she gained exceptional clinical experience. In 2018, she founded GI Nutrition Northwest LLC and opened her office in Southwest Portland. Tina is focused on helping individuals with digestive disease and conditions improve their quality of life using diet and nutrition therapy. Please welcome Tina Patnode.
Hello, good afternoon, everybody. Thank you for being here. And today I will be discussing diet therapy for inflammatory bowel disease. The objectives for today are to review the role diet plays in the pathogenesis of inflammatory bowel disease, to discuss factors to consider when deciding what diet to follow, and to review proposed dietary interventions to help treat inflammatory bowel disease. Crohn's disease and ulcerative colitis are complex digestive disorders that arise in genetically susceptible individuals. This is due to factors that both doctors have discussed already today, so involving the T-cell dysregulation, gut dysbiosis, environmental exposures, and certainly dietary factors. There is no definitive evidence that diet or one food causes inflammatory bowel disease. However, there is a growing number of studies that have suggested diet potentially plays a role in the pathogenesis of inflammatory bowel disease. Several studies have observed an increased incidence of inflammatory bowel disease in immigrants after moving to industrialized countries and adopting the Western diet. So there are several components to the Western diet that have been implicated in the pathogenesis of IBD. These include high meat consumption, high fat consumption, low dietary fiber intake, and the addition of certain emulsifiers to foods. Meat, particularly red meat, is a component of the Western diet that many suspect contributes to the development of inflammatory bowel disease. Meat contains sulfur amino acid that, when fermented by the bacteria, produce hydrogen sulfide. Studies have proposed that hydrogen sulfide contributes to the pathogenesis of ulcerative colitis by inhibiting butyrate oxidation, then impairing the intestinal barrier function, which increases intestinal permeability. Dietary fats certainly have been implicated in the pathogenesis of inflammatory bowel disease, especially polyunsaturated fatty acids. The Western diet, the average Western diet, has a 15:1 ratio of omega-6 to omega-3 fatty acids, and the suggested ratio should be a 2:1 ratio for optimal health. So just to give you an idea of which foods are high in the omega-6 polyunsaturated fatty acids compared to the omega-3s. So some examples of foods that are high in omega-6 fatty acids are processed meat, salad dressings, snack foods, certain fast food, vegetable oils such as corn oil, sunflower oil, safflower oil is another one, grapeseed oil as well. So these are foods that are higher sources of the polyunsaturated fatty acids, omega-6, excuse me. Omega-3s are found primarily in fish, so fattier fish like salmon. Also, omega-3s are found in halibut, tuna, For those who don't consume fish, you can also get omega-3 fatty acids from flax seeds, chia seeds, flaxseed oil. So those are some good sources of those. It's important to note that the polyunsaturated fatty acids are essential fatty acids, which mean that our bodies, we do not actually make these fatty acids, so we have to get them from our diet. So it's not that they are bad, the omega-6 fatty acids, but there really just needs to be a better balance in the Western diet. Moving on, I'll talk about the emulsifiers next. So emulsifiers are basically food additives that give food a smooth texture. They help prevent separation. They can extend shelf life. Emulsifiers are found in many non-dairy beverages. They're found in salad dressings, ice cream, to name a few food sources. While there are several different emulsifiers out there, those that have been strongly implicated in promoting intestinal inflammation include the three that I've listed here on the slide. So carrageenan, carboxymethylcellulose, or CMC, and polysorbate 80. There was one small random controlled trial that included 12 patients with ulcerative colitis that evaluated carrageenan consumption and risk of ulcerative colitis relapse. The study found that carrageenan consumption was associated with a higher risk of relapse. Now, granted, this was a very small random controlled trial, and so 3 of the 5 carrageenan consuming group was associated with higher risk of relapse versus 0 of the 7 patients in the placebo group. And I believe I noted that resource there on the slide. It was published in Nutrition Healthy Aging in 2017. Lastly, I'll just touch on the component of the Western diet that certainly is lacking in fiber. So fiber has numerous health benefits. In terms of inflammation, fiber is hypothesized to exert an anti-inflammatory effect via metabolizing the intestinal bacteria to short-chain fatty acids. And these short-chain fatty acids help maintain intestinal barrier function by preserving that inner mucus layer of the gut, of the intestinal tract. So the question that I often get from my clients is, what can I eat? What type of diet should I follow? I certainly want to point out that there are, many factors to consider when deciding which diet therapy may be appropriate. There is not any evidence-based data that identifies, specific food triggers that exacerbate IBD. The more common trigger foods, certainly that patients report that might trigger their symptoms, their digestive symptoms, include spicy foods, fatty foods, highly fibrous foods, dairy, beans, legumes, and then oftentimes alcohol can be a trigger. But the factors when evaluating diet therapy, you really want to consider several factors. The diet should be individualized and focus on inflammatory bowel disease treatment goals. So certainly, we're wanting to look at inducing remission or maintaining remission, goal to reduce the need for long-term corticosteroid use, certainly improving or maintaining nutritional status is important goal, improving quality of life, and certainly always considering the improving prognosis. So some factors I've listed here to consider when you're trying to determine what type of diet to follow. Certainly disease activity. Is the disease in remission, or is it in a flared state? Medical or surgical history. So has the patient had a bowel resection? Is there a bowel stricture? Are there adhesions in the bowel? Does the patient have an ileostomy? Is there potential for or small intestinal bacterial overgrowth present? So these are factors that the patient should work with their clinician, their doctor, their dietitian to help them determine what's going to be the best diet therapy going forward. So on to the next slide, I'll just move into general recommendations for, this would be when disease is in remission. So it's recommended, I typically am recommending when, to my clients when disease is in remission to follow more of a Mediterranean style of diet. This diet promotes a diet that's higher in the omega-3 fatty acids and lower in the omega-6 fatty acids, as I described earlier. The Mediterranean diet is high in vegetables, fruits, whole grains, those healthy fats, moderate intake of fish, poultry, beans, and eggs, and limits red meat. Meals preferably should be home cooked, and limiting the processed foods and food additives. So there are multiple dietary interventions that have been proposed to help treat IBD. I chose 4 today to focus on. They tend to be some of the more common ones that I am either working with patients on or getting questions about. So the low FODMAP diet, the semi-vegetarian diet, the specific carbohydrate diet or SCD diet, and lastly, the autoimmune protocol diet. And I'll discuss each of these in detail here going forward. So the low FODMAP diet, I just want to point out at the beginning that the low FODMAP diet does not address inflammation, but may help reduce gastrointestinal symptoms in those IBD patients who are in remission. So in other words, there's no inflammation present, but the person is exhibiting possibly some functional digestive symptoms. So they may be experiencing abdominal pain or bloating, gas, diarrhea, and or constipation. The low FODMAP diet eliminates carbohydrates that are poorly absorbed in the small intestine, and they are fermented by the bacteria in the colon or the large intestine. And this results in increased gas production and fluid overload, thus causing the symptoms I described earlier: the abdominal pain, the bloating, the excess gas, the diarrhea, and or constipation. FODMAP is an acronym, and it stands for fermentable oligodimonosaccharides and polyols. Again, these are groups of carbohydrates, so the diet primarily focuses on the carbohydrates. And fructans and galactans, those essentially they're incompletely digested in the small intestine, and they undergo that fermentation by the bacteria in the colon, and that's what can increase those symptoms. In the Western diet, fructans and galactans, the main dietary sources include wheat, onions, garlic, beans, and legumes would fall under the galactan group. Other types of carbohydrate intolerances, the most commonly known one probably would be lactose intolerance. And essentially, lactose intolerance can be present in young childhood, but certainly can develop in adulthood. And when it's when the small intestine can't break down the lactose. There's a lack of the enzyme lactase. Therefore, this is what causes when that lactose enters into the large intestine, it can cause that digestive distress. So often people experience pain, bloating, gas, maybe some nausea, and diarrhea, usually within 30 minutes to a couple of hours after consuming milk or dairy products. Fructose intolerance has become more common in the past, I would say, 20 years. It's estimated 1 in 3 people are diagnosed with fructose intolerance that have, the IBS type symptoms, can blame their symptoms partially on fructose intolerance. And essentially how the fructose works in the gut, it increases the water content. So pulls water into the gut, and that's what can lead to bouts of loose stool or diarrhea. The last group of the FODMAPs are the polyols, and these are also known as sugar alcohols. The more common ones that most people are aware of are sorbitol and mannitol. I usually tell my clients if it ends in OL, it most likely is a sugar alcohol. And sugar alcohols are poorly absorbed in all humans to a certain extent, but some people are more sensitive to them, and it certainly depends on your level of consumption, how much of them you're consuming in your diet. They're used in, as sugar substitutes, or artificial as a source of a sugar, replacing sugar, but they are also naturally found in many foods. So they are found in certain, stone fruits. They're found in cauliflower, so lots of different vegetables, mushrooms, avocados, and so there are many nuances to the low FODMAP diet, and what I always tell people is that it has nothing to do with the quality of the food that you're eating, but how these carbohydrates are being processed in your digestive tract. So as far as the studies that have been done, they're conducting more studies, the role of the low FODMAP diet in individuals with inflammatory bowel disease. This particular study that I noted here was published in 2017, but it was a random controlled open label study. It was 89 patients with inflammatory bowel disease. So it was quiescent disease, so it was either they were in remission or they had mild to moderate disease activity with some coexisting gastrointestinal symptoms. The participants had significant improvement in their GI symptoms and quality of life after following the low FODMAP diet for 6 weeks. There are 3 phases to the low FODMAP diet, so I'll just point out most importantly that it's not, this diet is not meant to be a long-term diet therapy. It is a test diet, so we are actually trying to determine if there is a carbohydrate intolerance that is present. So there, as I mentioned, the 3 phases. So the initial phase is the elimination phase, where we reduce or avoid all high FODMAP foods for a period of 2 to 6 weeks. If the individual does indeed have symptom improvement, then we would move into the next phase, which is the reintroduction phase, where we are gradually and systematically reintroducing high FODMAP categories one at a time to help us identify what the triggers are for you. And this is very individualized. And this is often the step where I have people coming to me who get lost in this process. Because it should be done in a very systematic way, introducing one category at a time. So it's very easy to get confused with food reintroduction and not being able to identify the particular trigger foods. The third phase is the maintenance phase, and this is basically, once we know what the triggers are for you, we work at essentially determining how much of that food or those foods in the particular category that you can eat and still keep your symptoms to a minimum. So the goal is always to have the least restrictive diet and to allow you to eat the most varied, nutritious diet as possible, while keeping the gastrointestinal symptoms to a minimum as much as possible. A little bit of history about the low FODMAP diet. As you can see here, it was developed at the Monash University in Melbourne, Australia. And so there's a team of researchers there that are pretty incredible. They have developed back in I believe it was 2012, the Monash University released this app. It's the first evidence-based smartphone application for patients and practitioners. It really has improved access to accurate and up-to-date information on the FODMAP content of foods. The food guide section contains detailed information about which foods are low in FODMAPs and the serving sizes that should be well tolerated by most individuals. Okay, so I'll move on to the next diet therapy I'm going to discuss today. Plant-based diets and semi-vegetarian diets have been suggested for inflammatory bowel disease patients because there is some evidence that diets high in meat and fat and low in fruits and vegetables may be associated with an increase in inflammatory bowel disease. These diets have not been well studied except for in Japan, where it is more common for doctors to recommend patients with inflammatory bowel disease to follow a semi-vegetarian diet, which includes eggs, yogurt, fruit, vegetables, legumes, brown rice, miso, pickled vegetables, with occasional milk and green tea. So this is not a vegan diet, but it is a lacto-ovo vegetarian diet. There's a small study here that I noted that was published in World Journal Gastroenterology in 2010. Was a small prospective study of 22 Crohn's disease patients. This found that patients on a semi-vegetarian diet were less likely to relapse with a flare after 2 years as compared to patients who did not follow a semi-vegetarian diet. There was a more recent random controlled trial in 2019 that was published in Gastroenterology. This was 213 Crohn's disease patients, found that reduced meat consumption did not reduce risk of flare. The average adherence rate was only 57%. So it's still really unclear as to the role, the benefit of reducing red meat consumption and its relationship to inflammatory bowel disease. So I just thought I would share that more recent study. Okay, so moving on to the third diet therapy, the specific carbohydrate diet. So the SCD eliminates carbohydrates requiring digestion in the small intestine It's based on the idea that people with Crohn's disease and ulcerative colitis have an overgrowth and imbalance of gut flora that can result in maldigestion, malabsorption, and inflammation. By removing these complex carbohydrates, the diet aims to restore microbial balance and proper digestion and absorption and heal the digestive tract. SCD would be used when the disease is in a flared state with the goal to get into remission. There's quite a bit of history on SCD. It goes back to the 1920s. First proposed by Dr. Sidney Haas, and was using this particular diet in children with celiac disease. And then it gained a lot of popularity after Elaine Gottschall published her book and was actually her daughter, who had ulcerative colitis, benefited from following the SCD diet. In the next slide, I listed several. I put this here together to just outline what is allowed on the SCD diet versus what is not allowed. So it gives you a sense. Essentially, the diet allows for most fresh fruits and vegetables, meat, yogurt. The yogurt is 24-hour fermented yogurt, which is essentially lactose-free, and then lactose-free cheese, hard cheese. Certain legumes are allowed. The diet does eliminate most grains, such as wheat, barley, corn, rice, and processed and canned foods are eliminated, and milk. Studies that have been conducted on SCD, the majority of the studies have been in the pediatric population, primarily children with Crohn's disease. I've included the results of a couple of studies here that have studied both pediatric and adult patients with inflammatory bowel disease. The first one outlining a case series of 50 adult and pediatric patients. The mean time to symptom improvement was 29 days. 66% of the participants reported complete symptom resolution. And the mean duration following the SCD was 35 months, and it had a pretty high adherence rate at 95%. The second survey study was conducted by Susskind et al., and this was published in 2016. But this was a study on 417 adult and pediatric IBD patients. The mean duration following the SCD was 32 months. 33% of the participants reported remission at 2 months following the diet. 42% reported perceived clinical remission at both 6 and 12 months, and 47% observed improvement in laboratory values. So currently there are 2 ongoing studies. This is I'm pretty excited about learning eventually the results of these 2 studies. The DINE-CD study is comparing the efficacy of the Mediterranean diet and the SCD in reducing symptoms and inflammation in Crohn's disease. And the PRODUCE study also, so this is an ongoing prospective study comparing the effectiveness of strict SCD with a modified SCD in reducing symptoms and inflammation in pediatric IBD patients. So we'll look to hear of these results. Hopefully, I'm not exactly sure when these studies are concluding, but certainly would be exciting to hear the results. Okay, moving on to the autoimmune protocol diet, or AIP. The AIP diet is a more restrictive version of the paleo diet. AIP focuses on healing the gut by eliminating foods that trigger inflammation in those with an autoimmune disease such as Crohn's disease or ulcerative colitis. There was a prospective observational study done in 2017 that showed 11 out of 15 adults with active inflammatory bowel disease reached clinical remission after 6 weeks of following the AIP diet. All 11 of the participants maintained remission during the maintenance phase. So this diet has an initial 6-week elimination phase that is followed by a 5-week maintenance phase. The AIP diet, like I said, is more restrictive version of paleo. So it does eliminate all grains. It eliminates legumes, nightshades, dairy, coffee and alcohol, nuts and seeds, and it eliminates refined processed sugars, oils, and food additives. Okay. So the takeaway here, is that there is not a one-size-fits-all diet therapy for those with inflammatory bowel disease. There are many factors to consider, such as disease remission versus flare, a person's nutritional status, certainly psychosocial aspects to consider. And it's imperative to work with your healthcare team to determine which diet therapy will best meet your needs. Okay, well, that concludes my presentation. I'm happy to take any